Welcome, everyone. I'm Tobias Mattei. I'm the deputy editor of the North American Spine Society Journal, and I have the privilege of having here with me today Dr. Robert Ravinsky. Dr. Robert, he's the senior author of a systematic review and meta-analysis published in NASJ entitled The Effect of Time to Balloon Kyphoplasty on Osteoporotic Vertebral Compression Fractures, a systematic review with meta-analysis. Thank you very much for your time, Robert.
Thank you, Dr. Mattei. I'm very excited to be here.
Perfect. So let's start first with what is the gap in the literature that you try to address with this meta-analysis? And tell me a little bit about your rationale. I know you probably have an extensive experience with cement augmentation. So go ahead.
Yeah, so it's a very interesting question. And, I don't currently do a lot of kyphoplasty right now, but in my current practice, I was in private practice for a few years in Phoenix, Arizona, before coming to the Medical University of South Carolina. And I did a lot of kyphoplasty there. And it was really interesting to just anecdotally see the outcomes in the patients. And this is not the most scientific way of looking at the problem, but of course, this is usually the basis of how these questions arise. I remember having a discussion with one of my very good colleagues, Dr. Brandon Hirsch, who was one of my partners at the time, and he's a co-author on the paper, and talking about how we've both kind of noticed that patients seem to have better pain relief with early kyphoplasty. Of course, in the real world, in practice, you need to get insurance authorization. There are scheduling issues. So sometimes, and you need to get advanced imaging before you do a kyphoplasty. So the amount of time that you may wait before doing the actual procedure and, leading up to that from the time of injury could be quite variable. So we kind of took a look at the literature and wanted to see what the best evidence was and see if there was a knowledge gap and if there was something that we could potentially contribute. So that was the rationale for looking at some of the outcomes associated with timing and balloon kyphoplasty.
Sure, and I can share my experience with these patients. I agree with you that there's a logistic issue in terms of, those patients have a fracture, the primary care orders an X-ray, and then they get to see you or some nurse practitioner. Then you still have to order an MRI, get authorized. So, and then you have to authorize the procedure after you decide that there are significant stir changes and the patient is in pain. So, it's a little bit of challenge to do before 4 weeks, but I think the main subpopulation that we could kind of apply what some of the results that you obtain in this paper are those patients that ended up presenting to the emergency department. They have an acute compression fracture. They have significant axial mechanical back pain. And still the traditional understanding is that you need to try a brace for 3-4 weeks before you're deemed that your conservative treatment fail. And by that time, either the outcome may be slightly inferior, as you demonstrated in the paper, or we've all done those cases in subacute fractures, and it's a little bit hard in the bone, and you're not even sure if you're still helping the patient, and you say, hey, I suppose this is a fracture, but maybe it's perhaps already partially healed. Maybe I should have waited 3-4 more weeks with the brace because I'm already past halfway of the conservative treatment. So let's start with the data from the paper. So tell me a little bit about how many studies you included and how many the patients, how you define early versus late treatment.
Absolutely. So, just going back to the paper, there were a number of different studies that looked at this particular question. I believe that we included 9 in total. And what we wanted to evaluate was the best outcomes. So for, I think in this population, the osteoporotics, the older patients, really, this is a question of quality of life. Pain scores really are going to be the key outcome measure that we're really interested in. At the same time, a big part of my practice is treating adult spinal deformity. So I tend to look at everything through a lens of deformity, and I think a lot of other surgeons are like-minded in that regard. So getting a sense of the radiographic outcomes with respect to segmental alignment seemed also to be quite reasonable. And I felt that these were very much tied in with some of the outcomes related to pain, and we can discuss that a bit further. But you're absolutely correct. There's usually so many different things that have to happen before you can actually get a patient a kyphoplasty, right? So it is very challenging to get a patient in before 4 weeks, and And to your point, 3 weeks seems to be sort of, at least in orthopedics, it's kind of the magic number where bone starts to stick together. And so you don't have a ton of time to get in there before the 4 week window. So that was how we sort of delineated between early and late. The interesting thing that we found in this paper, and there were many studies that looked at both the radiographic outcomes and the clinical outcomes, more looked at pain scores as opposed to segmental alignment. But we did find a few things that I think are extremely relevant. The first being that the pain scores just seem to be improved, and this was borne out in the meta-analysis. They were improved with early intervention, which makes rational sense, and we look at, whenever we do a study, we're looking for associations. We're looking to see if an exposure of interest and an outcome of interest have a certain amount of association in a statistical mathematical sense. But there also has to be a scientific rationale behind that. There has to be an underlying mechanism that, that can explain this association. And I think that, both of those elements come together in this paper. We did see that the early group had significantly better pain scores than the late group.
Was it measured? What was the time that the VAS and ODI were measured? Was it because I mean, I read the paper several times, and I couldn't find where I know there was a statistically significant difference, not only in terms of improvement in both groups, of course, pre to post, but comparing the early versus late group. The early group was superior in terms of ODI and VAS,
Yes.
but I couldn't find at what time point. Like, was it at the late follow-up or immediate
These were
follow-up?
these were at late follow-up, but a late follow-up in these studies doesn't tend to be very far out. We didn't have a lot of studies that had very prolonged long-term follow-up, and really that also goes along with the intervention itself. It's an intervention that's targeted at immediate pain relief. So to some extent, I think that needing very long-term follow-up is potentially somewhat less relevant than some other studies, but that's not to say that it's not relevant at all. And I think this really plays a role, in terms of the etiology of the pain that these patients are experiencing, which is multifactorial. But at long-term follow-up and at the longest follow-up in all these studies, I would say we did see improved pain relief in the early group.
And one of the things that you mentioned, and I thought it was very interesting because, I mean, I still tend to use the language of older study with my patients that say, I mean, the kyphoplasty, if your axial mechanical pain is bad and you cannot wear the brace, and especially, I mean, elderly patients, sometimes it's going to be challenging for them to brace. I mean, the cement augmentation, either vertebroplasty or kyphoplasty, tend to provide a substantial upfront relief of the pain. But I usually tend to tell them that at the long term, the outcome probably is going to be the same with the brace or the kyphoplasty if you're measuring 6 months or a year later. And I'm not sure if the literature really supports that. I was very kind of surprised by some of the discussion when you're trying to figure out why your early intervention would have better outcomes than later intervention. And I mean, a lot of the pain, we imagine this. I mean, it may not be that different if you imagine the therapeutic effects of the cement being, going through the cracks and stabilizing mechanically the vertebra. Some people think that it affects some of those terminations of the basic vertebral nerve, especially with the exothermic reaction. So, I mean, all those mechanisms should be about the same before 4 weeks or after 4 weeks. But you mentioned something very interesting that, especially in those patients with a little bit of further collapse, I mean, there's a whole cascade of deleterious effects upon the spine, which may not necessarily be a terrible worsening in the SVA, but I mean, there's overload of the facet joints.
Yes.
There's some changes, be it muscle spasms that are associated with that, which even if you treat the cause of the micro instability or the bone, I mean, those may still persist. So I think that's very interesting and really, I mean, puts into question our general thought that both treatments, conservative and cement augmentation, are the same, and it's just a matter of sharing the decision making with the patient. Of course, I mean, that's important, but it's just something to take into account, especially if you're planning to do the procedure.
Yes.
mean, there's no benefit in delaying. I mean, you're just causing those other pain sources to come into the picture, and then you may have a suboptimal outcome, and the patient, even though the fracture itself has been treated. I don't know if that's your kind of overall
You
thought.
know, I couldn't agree with you more. I think that you bring up so many important points, and this was really the you mentioned all the important factors that I think are related to the pain response or the pain scores that these patients are experiencing. Part of it is the micro instability of the fracture, but we all know that a fracture that takes 3 months to heal, once that's healed, there shouldn't be micro instability, and these patients do tend to have more pain, or they seem to have more pain. So there must be other factors at play here. And I think that activation of the nociceptors from the basivertebral nerve are important. I think that facet overload as a compensatory mechanism, again, doesn't necessarily mean that the patient is sagittally imbalanced, but you're forcing some of their already spondylotic joints to be mechanically loaded in ways that are not favorable. The tissue tension in the muscles and in the capsules and the tendons. So there's so many different things here, and I agree with you. I think that there is some degree of uncertainty or equipoise in our literature regarding a fracture that is going to heal eventually versus a fracture that gets stabilized with cement very early. And I'm not sure I have the right answer. I do think that there is a certain patient out there who is going to heal fine, who's going to have a good outcome and is not going to tell you that they're having tons of back pain. And there's another patient who really does benefit from the kyphoplasty. They're very different. They're very different people. And I don't know really, I can't really put my finger on what the difference is. You know what I mean?
Right. It's quite a challenge to screen those patients. We've all seen those patients that they come to our office. It's been 3, 4 months after either a traumatic fracture or an osteoporotic fracture, and you got a new MRI because there's still persistence of the pain, and the stir changes are completely gone. The bone is completely healed, and clearly, I mean, the patient and the family and everyone perceives that the patient now has some degree of chronic pain, kind of focal at the area of the fracture, plus the parapet muscles, and which was not there before. And that tends to be something that persists at the long term. And those are the patients that you question that whether you had done cement augmentation early would have helped. But again, I mean, what is that subpopulation of patient? I think we're still lacking um, any meaningful way to screen those patients so that we don't go from one stream of doing kyphoplasty for every single osteoporotic fracture we see, and at the same time that we miss those patients, and we all know the long term, not only socioeconomic impact, but financial impact of having chronic axial back pain, and the patients may persist for decades requiring injections around that area. One of the things that I'd like you to comment, so we discussed a lot about pain control in these patients. And it was very interesting to see the superiority of early kyphoplasty defined as, I think it was 4 weeks here,
Yes.
and before 4 weeks and after 4 weeks. But tell me a little bit about now the reduction of the fracture. I know you used two measures in terms of radiographic outcomes. One was the restoration of height, and the other was the focal kyphosis. And try to expand a little bit in what were those results. I can tell you personally, um, I do most of my kyphoplasties with the intravertebral body cages
Mm.
instead of using balloons. And I mean, from the
Like a
literature,
spine
they are
jack or something like this?
correct, spine jack, yeah. They are a little bit, so no disclosure, I don't have any conflict of interest with that.
Sorry,
Um,
no problem.
but correct. And I've seen some very impressive reductions with that I've not seen with the balloon. And I can tell you, I mean, those early patients are the ones that you have that we can see some very impressive outcomes. I think honestly, the best outcomes with spine jack are for traumatic fractures, not even osteoporotic fractures that I've had.
Mm.
Some patients that are, I've done spine jack plus percutaneous fixation because there's a small ligamentous injury, or purely spine jack. I know the literature on cement augmentation for traumatic fractures is not as robust as for osteoporotic fractures. But I can tell you, compared to my partners, I avoid several surgeries by just doing a spine jack kyphoplasty in a patient, for example, with a burst fracture, and even got some meaningful reduction, and even the posteriorly displaced fragment that some people worry ended up getting reduced in the same
Mm.
manner as ligamentotaxis. But back to the paper. So tell our listeners a little bit about the radiographic outcomes and how they compare between early and late kyphoplasties.
Yeah, I mean this was one area where just in general it did seem that there were better reductions. There were a number of studies that looked at the radiographic outcomes, and there did appear to be improvements in radiographic outcomes with early surgery, but the results were not as definitive as with the pain scores. And I think that you bring up an excellent point, Dr. Mattei, which is that this is with a balloon kyphoplasty, and a balloon kyphoplasty is a I don't want to say more rudimentary treatment, because I think a balloon kyphoplasty is an excellent treatment and it still works fantastically well and does a lot of good things for patients. But I also can tell you, as somebody who's done many kyphoplasties, even sometimes in an early fracture, it can be exceptionally difficult to get a good reduction and then hold the reduction with the cement. And I remember a few years ago, and we were already hard at work on this study. Spine Jack was gaining popularity, and I was seeing social media posts about it, and I was reading papers about it, and having discussions with the folks from Stryker. I have no disclosures, by the way, so same as yourself. Um, but I remember thinking like, oh, this is a really interesting device, because the alignment piece I think is really important. And I think that although a balloon kyphoplasty can improve your alignment, and this was borne out in our paper as well, we did see improved vertebral body height, and to a lesser extent improved segmental alignment. But I really do think that you can get a better reduction and a better restoration of segmental alignment with a titanium device like a spine jack.
And I
And
don't think there's any literature on that I've seen comparing balloon kyphoplasty. There's a little bit anecdotal, but my experience with the balloon kyphoplasty is similar to yours. I still think it's better than vertebroplasty because it's a low pressure cement injection. So I tell my residents, when I'm using a balloon, I'm mainly using to create a cavity in the vertebral body so that, my cement is, I mean, and that's from the literature. I mean, it's not only personal experience, but you have less, especially venous extravasation. I mean, if you do a high pressure injection, even in an early osteoporotic fracture, just a vertebroplasty, I mean, there's a tendency for the cement before it starts going through the crack, you start seeing that leakage through the veins anterior to the vertebral body. And I think that's one of the things that the kyphoplasty, you see the cement kind of filling that void initially. But at the same time, I've been very happy with the mechanic device, not only for the reduction of the fracture, but I have the feeling that the cement tends to stick to the device itself
yes.
and have a lower rate of extravasation. So no, that's very relevant. So one of the things that I think is very valuable for your in terms of your paper is that, I mean, we will all face insurance issues and authorizations. When we're trying to indicate a procedure and someone come with a failure of physical therapy or failure to pursue conservative treatment for this type of fracture. So honestly, I mean, this is a type of topic that I don't think you're going to be able to do a randomized control trial. I mean, it's always challenged to randomize patients based on the timing of intervention. The patient will, always question, hey, if you think the intervention is beneficial, I mean, why am I waiting for weeks just because the flip of a coin? So I always find that a little bit challenging. So we're kind of stuck with either prospective database or looking back retrospectively and seeing those patients that for whatever reason they ended up getting the procedure in a more delayed fashion. But I do think that this may be the best evidence in the literature for quite a while in terms of supporting our clinical judgment against some of the barriers that we find, especially regarding insurance authorization when for that specific patient we may believe that the patient warrant in intervention earlier rather than later. So thank for the great job.
Yeah, I mean, I think that you bring up an important point, which is that it's very difficult to randomize patients, and that's a bit of an unusual discussion that you have when you say,
Right.
well, we have two treatments here. We have one we think is better, one that we generally do normally, and then you propose this to them, usually in an emergency department setting. So it's a strange conversation. The other issue with randomized trials is that they demand a huge amount of organization and funding, and you need multiple sites generally. You need to have a large number of patients to appropriately power the study, and it's hugely challenging. I have a lot of respect for scientists who have gone to that trouble and taken that step and put together a randomized trial that usually takes 5, 6, or 7 years, and a lot of a big coordinated effort. But I agree. I think that the most practical way to really gain more insight and more granular data on this subject would be to have prospective registries where we can uh, collect the data prospectively and then refer back to the registries and use those sources of information to fill that knowledge gap.
And you mentioned, especially when we were discussing about timing of intervention for randomized trials, right? I mean, it may be a little bit easier to have the conversation with a patient and say, hey, there's a new drug or a new device in the market. We can do the traditional procedure with great outcomes. This seems to have better outcomes or maybe similar. We don't know. And you may be on either group, but I think you're getting as much as appreciative I am of evidence-based medicine, and I like to see good data as you provided in this paper. I always have in the back of my mind my wife who doesn't like doctors that much. And if she's in the emergency department and they say, hey, we don't know how it works, but we're going to flip this coin and we either get the surgery tomorrow or in 4 weeks. I mean, she's going to raise an eyebrow, and there's no way anyone can convince her that she's helping the progress of science with that. And I think it's, yeah, I mean, timing of surgical intervention for randomization is one of the struggles that we face to obtain this type of data. One of the things we didn't address, and I would like you to comment, and I don't think I've seen any literature on that, but it was interesting to going through the studies. There was some discussion about possible increased rate of cement extravasation with early kyphoplasties, and then some authors that mentioned that if you do in a more delayed fashion, there's already some degree of end plate regeneration and maybe some fibrous tissue in the bone marrow, and they may reduce, especially leakage toward the disc space. What does the data tell us about that cement extravasation comparing when comparing the early versus the late group?
I think that, there was that finding that there may be a bit more extravasation in the early group, but I really don't think that the data is compelling enough for us to hang our hat on it. Again, the mechanism makes sense. There's likely some callus formation, there's likely some containment to the cement, and this may account for the reason why there seems to be less extravasation. I think at the same time, surgeons in particular, like, are a little bit cautious when they're doing the really old fractured kyphoplasty. They know that if they pressurize it too hard, there's going to be cement leakage. So I wonder, it's a multifactorial thing. Is there a bit more caution? Is there a bit more reticence? Is there a bit more kind of gung-ho enthusiasm for the early fracture where you just want to load it up with cement and get a really nice reduction? So I think it's a little hard to say, but I do think that the fibrous tissue, the callus formation, I think all of this sort of plays into it. For me, what I think would really make the difference in terms of understanding this this admittedly mild difference in cement extravasation would be to understand what types of volumes of cement were used in the early versus late group, and we just don't really have good information about that.
And one personal experience that I would like to get your opinion on is that, like, when I started doing these cases, I mean, we all know that we always go by the stir hyperintensity or the T1 hypointensity. I mean, those are the markers of acuteness, or at least acute/subacute, the benefit. I mean, you don't want to do a kyphoplasty in a patient without stir changes. And I always thought that was a marker of broken bone in some way, or I mean, bone marrow edema. There we go. But I don't think we have a good idea of the actual cellular changes or microenvironment that lead to the progression of the stir changes. And by that I mean, I can see the same patient with stir changes in the vertebral body, in a non-healing fracture in 3 months, and in an acute fracture. And the tactile feedback when you do the kyphoplasty is completely different. I mean, the stir changes in the early fracture represents broken bone, is very mushy, and you have to be very careful even to not let your gem sheet needle plunge too far. And then you see some patients with persistent fractures or persistent pain and stir changes late, maybe 3 months, and you say, hey, I mean, you're still a candidate for that. And when you go do the procedure, you have the feeling that, I mean, the cement fills the void sometimes, that there's some air gaps within the vertebral body, those voids that you know are related to the pain. But the bone itself seems almost completely healed, and you still have those stir changes. So those are the patients that sometimes I question, hey, I think the indication was very good based on the MRI changes and the persistence of the pain. I don't know what I'm doing here. Like based on if it's getting so hard and I need to use a mallet to get the gem sheet needle to progress even from the posterior third a little bit forward, am I really helping this patient with the cement augmentation? I don't know. I just want to throw that out then to our listeners.
I think this is an excellent point, I have the same thoughts. I have the same feeling, and I have a few thoughts about this. The first is that it's the best we've got for now. I mean, I think that it's safe to say that a patient without stir changes is not somebody that you would recommend this procedure for. And I think that that is on one hand an important part of the decision making. You're right that a patient can have edema and T1 hypointensity and an intense and high signal on the inverse recovery sequence that could look sort of similar when you compare a subacute to an acute fracture, and feel absolutely completely different. The other thing that makes it a little bit complicated is, there are logistics in the real world that go beyond the academic discussion of, who's a good candidate, somebody at 4 weeks, 8 weeks, 12 weeks. And once in a while, you have a patient who had an MRI, say, maybe at 6 or 8 weeks after their fracture, and they have, high signal on the inverse recovery, but for one reason or another, it takes another 4 or 6 weeks to get them their procedure. So, you know, what their MRI looks like the day that it was done versus the day they had the procedure could be different. So there's more than one factor there, and I think that's probably the take home is, you know, there's a lot of uncertainty in spine surgery. As any spine surgeon knows, we use the best literature that's out there, we use the best data that we have, and we use the best diagnostic modalities that exist. But we also recognize that, our science is, it's there are knowledge gaps to be filled. So we do the best job we can. And I think that if you have a patient who's got a lot of pain, it correlates well with their scan. They've got high stir signal on the scans. I think once you've taken that step and you've made the combined decision to proceed with this elective procedure, you try to just do the best job you can. You try to get them in as early as you can. But I agree with you. I think that there is definitely there's opportunities for improvement with respect to imaging modalities. And I wonder if perhaps we may have imaging modalities that are more helpful in the future. I mean, there are some people out there who are looking at SPECT CT scans in fragility fractures. The data is really kind of not overly compelling, but I wonder if there may be some more appropriate imaging study that could be more helpful than a routine MRI somewhere down the line.
Nuclear medicine has always been an option, right? We always have those patients that cannot have an MRI because of a pacemaker. And like you mentioned, the fracture may be 6, 8 weeks. You don't know if it's still the source of the pain. And we get a bone scan, and then you see lighting up on the bone scan. It doesn't even need to be a SPECT CT with a better quality. But I agree with you. I mean, it would be even very naive to think that the microenvironment of the fracture will be exactly the same immediately after the fracture or a few days after and 6 weeks or 8 weeks after. Even though the imaging may look the same in terms of the stir changes, there's some progression of whatever is going there. May not be full-blown callus formation and restoration of the structure of the vertebral body, but something else is going on in terms of fibrous tissue and proliferation of fibroblasts and things like that that may still be related to the increased content of water associated with the stir change. So very, 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 very thoughtful what you said. Anything else you would like to our listeners to know? I think we discussed it very well, and I'm very excited. I mean, I was very enthusiastic about reading your paper, seeing the results. I'm a little bit of a big kyphoplasty proponent, and if I do, I tend to do in the early stage. So it's good to see that this data kind of supports some of my decision making.
Well, I mean, again, I just want to thank you for having me on this podcast. I was incredibly flattered and excited to be here and to kind of share some of the results of our study. I agree with you. I think a kyphoplasty is a very good procedure. I think that we're having newer techniques that are coming out that are exciting, like the titanium cement augmented procedures, like the spine jack. And I think it's important as surgeons to advocate, for early treatment for our patients, and to do the best we can to lobby with the insurers and with the political action committees to try to get expedited care and timely care for our patients. So I think that having this piece of literature that's now out there and it's in the big wide world, I'm hoping it'll make a positive contribution. And I think that if you have a patient who you think needs a kyphoplasty, it's just better. It's likely better to do it earlier.
Perfect. Thank you very much, Robert, for your time, and we thank our listeners. Keep tuned in the NASJ podcast.
Thank you so much.